So we are learning about blood transfusion. Blood transfusion, you should know about blood grouping systems. So most commonly used is ABO and RH blood grouping. But you should know other names like L, Lewis, MNS and Duffy. Regarding ABO blood grouping, so it is on the chromosome long arm of chromosome 9Q. And RH it is chromosome 1. The antigen which we consider in RH is D antigen. So based on this ABO blood grouping we have A, B, AB and O. And RH we have RH positive, negative. Then Duffy antigen. So Duffy antigen is actually a receptor for Plasmodium vivax infection. So if a person is Duffy positive, then he is having increased chance of infection of this Plasmodium vivax. If it is negative, then it is resistant to infection. He will not be getting affected. So next we have to learn about this ABO in detail and what is this Bombay blood grouping. For that, you should know ABO blood grouping means, see this is an RBC and this RBC is having an H antigen. Okay. And this RBC if having H antigen with some other antigens. So based on that, the blood grouping system will change. For example, H antigen and it is having N-acetyl galactosamine. That is when we say it is. So in ABO blood grouping, the most important thing is H antigen. Because in all ABO blood grouping, you will get this H antigen. If it is having additional NAG, then we call it as if additional it is having NAG, then it is blood group A. If it is having galactose, NAG means N-acetyl galactosamine. If it is having galactose, then it is B. If it is having both NAG and galactose, it is AB. If it is having only H antigen, it is blood group O. So what will be the antibodies present in A blood group? Anti-B. Here it is anti-A. Here you have both antigen for A and B, so you have no antibodies. Here you have 0 antigen, so both anti-A and anti-B. So this is important. If you have A antigen, then the antibody will be anti-B. Theory of major cross matching and minor cross matching. So major it is if you have an antigen, corresponding antibody will be absent. For example, if you have A antigen, A and anti-A will be absent. Minor theory says that if you have a particular antibody, corresponding antigen will be absent. For example, anti-B antibody you have, so B antigen is absent. When you do blood grouping, this is the slide, tile method, you know tile. So you know the color, you're adding blue, yellow, and next is actually gray. You remember this? This is the color of anti-A antibody. This is the color of anti-B antibody. So suppose your blood group is O positive. So O positive means you do not have antigen. You have both anti-A and anti-B antibody. So you are adding this blood like this. So here you do not have any antigen. For easy understanding, I am drawing like this. So here what we added is anti-A antibody, blue color, BYG, that is the mnemonic. This is anti-B, this is anti-D for looking Rh positive or negative. So here in O positive, A antigen is absent, B antigen is absent, and D antigen is present because it is O positive. So you get clumps in this chili pepper appearance on this point only. Okay, this is the way how you get. So how to differentiate O blood grouping and Bombay blood grouping? That is the next question. What is Bombay blood grouping? That you should know first. Bombay blood group means, see, that is the important thing that I have told. In ABO grouping you have H antigen, but Bombay you have nothing. Since you have H antigen in ABO, see the antibodies are like anti-A, anti-B, like that. But in Bombay blood grouping you have anti-A, anti-B and anti-H. This is the key point, anti-H. So anti-H is the important thing that you should remember. So once again I am saying regarding this, Bombay blood grouping and ABO, H antigen is present, is absent. So in a blood grouping, suppose you are adding anti-A, anti-B, anti-D and anti-H. 2 tiles. So in one tile you get clumps here. So in one tile you do not get any clumps. Now what are the blood groups? You just imagine here antigens. Now what you can understand from this picture is A is absent. Which are the antigens negative? B is also absent. Rh is absent. H antigen is present. So what is a blood group? O negative. O negative. Now in this picture, A is absent, B is absent, Rh is absent and H is also absent. So H is also absent. This no antigens are present. What we are saying is about antigens, okay? So this blood grouping is Bombay blood group. So what you can able to differentiate is just by looking this point. That's important. Next, we will discuss about who can donate blood. So age 18 to 60 years. See, very old patient cannot donate. Very young baby cannot donate. So that's the concept. And around weight should be 45 kg. Now you are doing screening for 5 diseases. Which are they? Which are the diseases that you screen? So see, if initially the patient is asked to fill his details like about his age, weight and all. Then later we look for the vitals, whether they are okay or not. Then next we will go for this screening for this diseases. So it include HIV, HBV, HCV, syphilis and malaria. HIV, HBV, HCV, syphilis, malaria. So initial blood can go into a bag called a pre-donation bag, small amount of blood. That is because from the skin you can have a lot of skin colonies. So such organisms, after puncturing, such organisms can also be there around that cannula, so that you can eliminate that. Next is a leukoreduction. When you study the complications of blood transfusion, you will see some important complications like febrile non-hemolytic transfusion reaction. You have to remember which are the complications we are talking about. Non-hemolytic transfusion reaction, then graft versus host disease, like this. So in these cases, the donor and the donor blood contains some WBC, which is responsible for releasing cytokines and causing this complication. So what we do is leukoreduction. We will take a bag, it is having a charge in the bag, it will attract the opposite charges, likewise it will attract the WBCs. So all the WBCs are filtered out. That is how we can reduce this complication. Okay, so a patient, we are actually taking the blood. When you take the blood, what happens is, so as I have told, initially it can go into a pre-donation bag or it can go into leukoreduction bag. Later it is reaching into collected in this bag. So what is present in the bottom layer? This is RBC. Then you have something called Duffy coat. Then you have platelets. So what are these things? This is packed RBC. This is Duffy coat. Duffy coat means WBCs and all. This is platelet rich plasma. So you can connect this into a bag like here and here. You can press over here. So what happens? All this RBCs move into this bag. And all the plasma will be here. Here itself it is forming two types of layers, like here here it is platelet rich plasma. So what happens here is all the platelets will be down, and above you have platelet poor plasma. Platelets are sedimented bottom. And what is this? packed RBC. So this is how you are getting. Now you can take this part out. That is, you are connecting this into a bag and you are taking out this platelet poor plasma. So this platelet poor plasma you are keeping in the refrigerator. You are keeping it inside. Okay, this is the refrigerator. So when you keep this inside, that is actually fresh frozen plasma. After keeping this platelet poor plasma into refrigerator, now when you take it, it is called fresh frozen plasma. You can take it out and put it in the room temperature. That is called thawing. Thaw. Then what you are getting is called cryoprecipitate. So this is the order. Initially you can take a pre-donation bag or leukoreduction. Then you have packed RBC, Buffy coat, then platelet rich plasma. Later it will become platelet and platelet poor plasma. Packed RBC will go into a separate bag. Then you have the platelet poor plasma becoming fresh frozen plasma when you keep in the refrigerator. After thawing, it is cryoprecipitate. So what is the difference between these two? So here you have to thaw it for 12 hours. I can show you like this. Again, this is the fresh frozen plasma you have taken from the refrigerator. Hours you are keeping it in the room temperature thawing such that you are connecting it into a separate bag. So what happens? All the plasma will go down and something will be left. That is called a precipitate. All the plasma is going down within this period of 12 hours and what is left is the precipitate. So that is called cryoprecipitate. That is how you are forming cryoprecipitate. So what is the difference between fresh frozen plasma and cryoprecipitate? One is it is taken, this is after the putting in the refrigerator, it is called fresh frozen plasma. Cryoprecipitate means after thawing it for 12 hours. But what are the components that you can have inside this? Let us see that. So all coagulation factors minus factor 5 and 8 is fresh frozen plasma. Cryoprecipitate means it is having factor 8, von Willebrand factor and fibrinogen. So if a patient is having hemophilia A, then it is deficiency of factor 8. So you have to give cryoprecipitate. Then von Willebrand's disease, it's very easy. That means cryoprecipitate is in factor 8, factor, von Willebrand factor and fibrinogen. So it is given in hemophilia A, von Willebrand disease or hypofibrinogenemia. Easy to remember. Next is packed RBC. So we have got an idea about cryoprecipitate and fresh frozen plasma. So when we will give fresh frozen plasma, When there is a clotting factor deficiency, you can give like hemophilia B, you can give fresh frozen plasma. So next is packed RBC. We are adding some anticoagulants and preservatives to store. That is providing the shelf life. So we are discussing about some of the anticoagulants or preservatives that we are adding in the blood bag. So usually the packed RBC is stored at 4 degrees Celsius. That is the storage temperature. So in this bag you have some additives like CPDA. So the lowest value is ACD. It is acidified citrate dextrose. The next is actually 28 days, that is CPD, citrate phosphate dextrose. The next is CPDA, citrate phosphate dextrose adenine, 35. Then SAGM, saline adenine glucose mannitol, 42 days. So what is the importance of this mannitol is because it is preventing hemolysis. Glucose is providing energy. Then citrate phosphate dextrose adenine. Why CPD we added A, adenosine. Citrate phosphate dextrose adenosine. Adenosine is actually ATP, energy. So mostly we are using these two now, CPDA and SAGM. So this is the storage temperature. Packed RBC can be stored at 4 degrees Celsius for 35 days or 42 days, depends upon the preservative. Fresh frozen plasma, cryoprecipitate, they are stored at minus 30 degrees Celsius, can be kept for 1 year. Then platelets are stored at around room temperature 20 to 24 degrees Celsius, can be stored up to 5 days with agitation if they are kept with agitation. Without agitation, then it is only for 1 day. If it is without agitation, 1 day. So this is almost room temperature, that is increased chance for infection. So when you do blood transfusion, packed RBC, you have to start transfusion within 30 minutes and you have to finish within 4 hours. Platelet and fresh frozen plasma, you have to start immediately and finish within 30 minutes. So practical aspect, when you think you have to transfuse first platelet, then complete within 30 minutes, then you start giving packed RBC and finish within 4 hours. So that means you have taken the platelet bag and packed RBC bag separately from the refrigerator. So packed RBC is actually 4 degrees Celsius. So you have taken it from the refrigerator and you can keep it for 30 minutes near you and start giving after giving this platelet. That means you can start within 30 minutes. Complications of transfusion. So most common is given first. What is the most common? Febrile non-hemolytic transfusion reaction. So it is non-hemolytic. It is not because of hemolysis. It is febrile. Patient presents with fever and it is because of the WBCs that are present in the donor blood, antibodies are acting against that. Cytokines are released and that is causing fever. So you do not want to actually stop transfusion. You can continue, it is self-limiting. You can give antipyretics. So for prevention we have told the leuko reduction. You can filter the WBC out. Next is allergic reaction. It is because of the release of histamine. Patient is presenting with urticaria and itching, so you can give diphenhydramine injection. Then anaphylaxis is because of the release of histamine. Histamine is causing bronchospasm. Blood pressure is decreased, so you can give adrenaline. It is the physiological antagonist of histamine. Adrenaline is given in which way? What is the form you can give adrenaline? It is give subcutaneous. How much? 0.5 milligram. Dilution 1:1000. If it is IV, 1:10,000. Then graft versus host disease. Before that, acute hemolytic reaction or mismatched blood transfusion. So it is because of the hemolysis that is happening. So it is, if you are giving A blood group to a recipient with B blood group, there will be hemolysis. So it is an error. What is the hypersensitivity reaction? Type 2 hypersensitivity reaction. That means cytotoxic. Cytotoxic means antigen are present on the RBC. So the reaction is against that. So what happens? Can go for hypotension. Chest pain can occur, affecting the coronary circulation. If it is affecting the renal, causing acute tubular necrosis, flank pain. Because of the hemoglobinuria, we have told acute tubular necrosis, AKI. AKI can occur, renal cause AKI can occur. Next, graft versus. So what is the, you have to stop transfusion. You can check the blood group and cross matching. You can repeat blood grouping, correct the error. You can give furosemide because renal failure may be there, so you can give a diuretic. Graft versus host disease means after a blood transfusion or if there is any stem cell transplantation also, this can occur. So this usually occur between first degree relatives. For example, Ramu has got an RTA, severe blood loss, and he need blood for transfusion. So his brother Somu came to hospital. Somu gave the blood. Now after 1 week, this Ramu came to hospital saying fever, jaundice, diarrhea, pruritus and all. So one thing that can happen here is graft versus host disease. When there is first degree relatives are giving blood, in that cases they are sharing, why this is occurring is they are sharing common HLA antigen. That is the reason. So how can you prevent? One thing is, we have already said, leuko reduction, filter WBC. Second thing is you can irradiate the blood, because most radiosensitive cells in our blood is lymphocyte. So you can give radiation to this blood. And what is the least or radio-resistant cells in the blood is platelet. Next is TRALI, transfusion-related acute lung injury. So, this is the most common cause of death after blood transfusion. Most common complication is febrile non-hemolytic transfusion reaction. But most common cause of death after blood transfusion is TRALI. And the important thing is it's more occurring within 6 hours of transfusion. See, why this is occurring is this TRALI is because of the antibodies in the plasma. Donor's blood is having some antibodies. So these antibodies will cause aggregation of the WBC in recipient. Will cause leukocyte aggregation, and that can block pulmonary circulation, pulmonary capillaries. So there will be ventilation perfusion imbalance, and it is acute respiratory distress syndrome like manifestation. Or these antibodies in the donor blood can cause release of cytokines in the recipient, which is causing capillary permeability of the pulmonary capillaries, which is causing non-cardiogenic pulmonary edema. Are you getting this? It's the donor. Donor's blood have lot of antibodies. In the recipient, it is causing leukocyte aggregation, or it is causing release of cytokines. So because of this leukocyte aggregation, small blood capillaries can be blocked, or it can cause capillary permeability. So fluid ooze out. So it is causing non-cardiogenic pulmonary edema. Once again I will say, in the donor, you have a lot of antibody, and in the recipient it can cause leukocyte aggregation, or it can release cytokines. So what happened? Small capillaries are blocked. So the oxygen carbon dioxide perfusion doesn't occur. Ventilation perfusion imbalance, or the capillary permeability has increased. Fluid is oozing out, causing edema, non-cardiogenic pulmonary edema. So who are the people who have a lot of antibodies who received multiple blood transfusions? Or multiparous women, means who have had a lot of pregnancies, more antibodies will be there. So such people, if they are the donors who are multiparous women or who had multiple transfusions previously, and more commonly this can also occur with fresh frozen plasma rather than whole blood. Why? In plasma you have a lot of antibodies, isn't it? So all this are the risk factors for developing TRALI. So because of this, you have problem in the lung. So within 7 days symptoms will develop. That means within 1 week. So within 1 week symptoms will develop. So chest x-ray will be abnormal. Chest x-ray you can see infiltrate, bilateral infiltrate, blood pressure or JVP all will be normal. BNP is also normal. Why I am saying this? You have another condition called TACO. Transfusion associated circulatory overload. Suppose in a patient you give blood transfusion after patient is, when you look the BP is elevated, patient is having respiratory distress, crepitations are heard, so that is TACO. There is circulatory overload. So how to differentiate? It is not crepitation. Crepitation you can get in both lungs getting affected. But BP will be high, JVP will be high in TACO. Next thing that can occur is electrolyte imbalance. Electrolyte imbalance is, one is metabolic alkalosis, because you have citrate in the blood, in the preservative. Citrate will cause metabolic alkalosis because it will go to liver and citrate will produce bicarbonate. So you get metabolic alkalosis. Why hypokalemia? Hypokalemia and hyperkalemia can occur, but mostly it is hypokalemia. Hyperkalemia because inside the RBC you have potassium. So because of the lysis of potassium in the blood, hyperkalemia occur when there is hemolysis. But hypokalemia is more common. Why? Because metabolic alkalosis. So hypokalemia. Hypocalcemia because citrate will bind with the calcium. So calcium will decrease. There can be manifestations of tetany. So after blood transfusion, patient complains of numbness. Iron toxicity can occur because iron overload. So that can increase the levels of storage form of iron, that is serum ferritin. So you can give chelators. Desferrioxamine is given injection. Oral is deferriprone. So iron can get deposited in the skin, hyperpigmentation, in the pancreas, diabetes, bronze diabetes, liver, it can cause cirrhosis. Trally and TACO. So trally means we know it is mainly antibody, so mainly related with the plasma, but TACO all blood product can cause. Trally can occur within 6 hours of transfusion. That is important, within 6 hours. TACO can occur only within, the symptoms initially occur within 12 hours of transfusion. We have told a duration of 7 days and all, that is the maximum duration. But minimum is the 6 hours. So this is important. This is 12 hours. So fever is present in trally. Fever is absent in TACO. Then everything is normal. BP, BNP, chest X-ray can have changes or not. So this is not that much. You remember only easy things. And here you have circulatory overload. So diuretics will be helping for improvement in TACO. Crepitations you can get in both. So crepitations are not a character to difference. Then next is infections can occur, though we have screened for infections. What we have called that term? TTI, transfusion transmitted infection. Other infections can also occur because we look only for 5 disease screening. They can transfer some other viral infections also, HTLV. So increase the risk of infection is with the platelets. Why? Because platelets are stored at room temperature 20 to 24 degrees Celsius, and decrease the risk is with the fresh frozen plasma. Why? Because it is just a plasma. Because it is just, so we know plasma is actually having antibodies, so it is causing TRALI, but the infection risk is very high. Okay, that's about this topic. Thank